Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel. And if you're in my Facebook group on the Motor Point Acupuncture with Richard Hazel, you probably saw the research that I posted there. You can download the full PDF and see all of the images. But the point I wanted to make is that I found it a very interesting published article in Anatomy. It's a medical journal out of New Zealand. And what they did was they took 11 cadavers and they did biopsies of the tensor fasciae latae, the TFL, the Gluteus Medius, and the Gluteus Minimus. And what they were trying to determine was if they are primarily phasic muscles or tonic muscles. And tonic, for those of you who don't follow the school of Yanda's thinking, tonic or postural muscles. So you could say postural and phasic muscles. Phasic muscles have the type 2 fibers that do fatigue easily and can become inhibited from pain, injury, but they don't tend to tighten and shorten. Whereas the type 1 fibers are the slow twitch, non-fatiguing muscles that keep us standing up and stabilized, etc. And those muscles are prone to tightening and shortening. And in the school of Yanda's cross patterns, you will see a lot of those tonic / postural muscles shorten, like hip flexors, lumbar extensors, neck extensors. They are very prone to tightening and shortening. They don't fatigue easily, but they shorten. So the price we pay for muscles that will not fatigue and cause us to drop our head, not be able to hold our head up, are that they will shorten and eventually cause postural issues. And for those of you who do not agree with the Prague School guys, the Yanda and Levitt, the people that I consider complete geniuses, you may not believe that posture causes pain, but when you find people who are in pain, you can use the cross patterns to remember what are the short postural muscles that are very likely causing pain. And you can use the cross pattern phasic muscles to know where to look for muscles that have become inhibited and are no longer stabilizing properly. Phasic muscles don't often cause pain directly. They cause pain by losing their strength and no longer being able to stabilize. And then you have postural muscles that have to work harder for joint stabilization. And those postural muscles will shorten, and shortened muscles that cross joints will cause joint pain and tendinitis, and eventually bursitis or osteoarthritis, etc. So in the Yanda school, we like to follow the cross patterns because that helps tip us off to what will be too short and is likely the primary source of joint pain or tendinitis, inflammation, etc. So I found this article interesting because it backs up the conclusion that I've already come to and have talked about before, which is that the Gluteus Minimus and Medius are very prone to shortening. They're not just phasic. We kind of learned from physical therapy, physiotherapy, rehab, that the glutes become inhibited. the glutes have amnesia and don't function properly. And by the way, they do, from their biopsies, they did see that the glutes do have somewhere in the 40% range type 2 fast twitch phasic muscle. So they do have power, and they do have fibers that will become inhibited by pain. But more than half of the fibers that they saw in the gluteus medius and minimus were the type 1 postural muscles that are going to be prone to tightening, shortening, and becoming weak. Tightness weakness is what Yanda would call it. So why is this relevant? This is relevant because it's important to understand why we're treating what we're treating. It's, when you first start out, if you just say, okay, well, I know from so-and-so that for this condition, I should treat the gluteus medius and the TFL, for instance, and then they get better. But it's really important to understand why it helped. So I think it's really helpful, useful information from this journal article that that the gluteus medius and minimus are becoming short and tight. And it explains things that we see in our patients regarding flexibility after we treat the gluteus medius, and they can bend over and touch their toes better, or they can cross their legs without pain, things like that. Those are things that we see, and very often we have to say, well, I've been told that the glutes are phasic and become inhibited, but in my experience, they also become short and tight, because when I treat them on patients, I see improved flexibility. But now we have published histological research showing that, in fact, the gluteus minimus and medius are more postural than phasic. They're more tonic than phasic. And this would explain why the gluteus minimus gets so dense on so many people. And I probably have mentioned it like 3-4 different podcast episodes already, so I won't, beat a dead horse. But the gluteus minimus is so huge, so hugely important for hip dysfunction, causing pain in the joint, on the outer part of the trochanter, or even in the joint, in front of the joint, especially where it attaches. So, gluteus minimus, it's good for, I think it's nice to see that my assumption has been correct, that it is tight and ischemic and more like a postural muscle. So we should consider it that way, and we should consider treating it for anyone where we're trying to improve their hip mobility. The TFL, interestingly, has 55 or more percent type 2 fibers. So that makes it more phasic than tonic, which I find interesting, because I really see that TFL does get tight on people, and it can cause a lot of problems, especially like IT band syndrome. You end up treating a lot of, you have to test the person's hip to really know what that specific person's problems are. But I can tell you that on almost everyone with IT band syndrome, you will be treating gluteus minimus and gluteus medius and TFL. Almost everybody. Now, some people, you're going to find other things going on, vastus lateralis, or other deep rotators like piriformis, or the obturator internus, gemelli. There are lots of things that can cause tension on the hip, that will cause the internal rotators like TFL and glute min to get tight. So it's not one size fits all. But if you listed successful treatments of IT band syndrome, 10 of them, and what you treated, they would all include gluteus medius, gluteus minimus, and the TFL. And many, many of them will include vastus lateralis, and a lot of them may also include biceps femoris. Anyway, so I thought this histological study was really helpful and important because I like to feel confident when I'm telling a patient that this is what's happening, that there is science that backs up what I'm saying. Otherwise, I have to say, well, they say this, but I often see this. And I much prefer to say that the experts who are doing the scientific research back up being able to say that the gluteus medius is prone to shortening. The gluteus minimus is prone to shortening. It is what we see clinically, and I like being able to say I can point you to the research. So that's relevant. Interestingly, I was thinking about the Yanda approach to treating tight tonic muscles. I think very often they're going to be stretching the tight tonic muscles, and when dealing with the phasic muscle, you very often want to consider the antagonist that is very likely a tight tonic muscle. So I was thinking about that and the hip, and that maybe instead of trying to strengthen inhibited gluteus medius and minimus with clamshells, they should be doing some stretching of the gluteus minimus and medius for somebody who is having maybe like a Trendelenburg kind of hip drop, sagging hip because they're not having good stabilization in the hip. If you don't have needles, then you need to somehow address the chronic shortening of the gluteus medius and the minimus. So I was thinking probably you need to get in there doing some myofascial work, some active release technique, some pin and stretch sort of stuff. Probably have to do some good stretching for that. Luckily, we have needles. You can put a few needles in, and 10 minutes later or less, the person will have much better flexibility, much better elasticity and strength, and good stabilization for their hips. It's another thing to consider. Tight gluteus minimus and medius makes the pelvic stabilization weaker. So when you're dealing with those issues, it's always good to check the contralateral QL, because the weak abductors, when they're not able to stabilize the pelvis as well for walking, standing, running, the contralateral QL will work harder to maintain the pelvis in alignment. We basically say in alignment with the horizon. So if you're standing on one leg and your gluteus medius and minimus are super tight and weak, and maybe your TFL is fatigued, unable to maintain pelvic stabilization, then your QL will work harder to keep the contralateral QL will work harder to keep your contralateral hip from sagging down. So the QL, it's important to remember, is part of that pelvic stabilization. Because of that article, I then was thinking, I bet there's some research on the transverse abdominis and fiber types. And I mean, I didn't pay to download the whole research article, but I read the abstract, and it does look like there are similar studies that are backing up that all the abdominals are, I don't know about rectus, but I know about the transverse and the obliques are more type 1 than type 2, meaning they're a balance, but a little bit more on the tonic postural side than on the phasic side. So, we hear a lot about abdominals becoming inhibited, and in fact they do. Pain will inhibit abdominals. And if you've worked with anyone who's had any kind of surgery that affects their abdominals, they absolutely do become inhibited. And electric stim acupuncture is one of the best ways to get them firing again. A needle in the motor point of the transverse abdominis or the external oblique or internal oblique can really get those muscles firing way better. And I've done that for rectus abdominis too. You'll see that after childbirth for women, regardless of whether it was a C-section or natural birth, their abdominals will be wrecked by, I think, probably just by being stretched for so long. So you'll see when women want to get back in shape after giving birth, they will be frustrated that they can't get their abs to fire. Sorry, you hear my dog dreaming in the background. He's, I don't know, chasing something or I don't know. Anyway, but he's fine. If you hear that, he's fine. So, my experience has been that you see that the abdominals get super tight on people. So I think part of their weakness and their lack of ability to stabilize the core can also be from overuse and becoming short and tight. I feel like that's like been my biggest issue with my abs is just I feel like they're super tight, and my QL, and that affects breathing. So it affects our core stabilization. It affects breathing. So I don't know. I think it's worth looking into if it interests you to see if, as an orthopedic acupuncturist who wants to be able to consider what's tonic and what's phasic, what is tight and weak, and what's weak because of pain and because it's more type 2 phasic fibers that have become weak. It's good to dive into the research because if you like to have a different electric stimulation protocol for tight muscles as opposed to inhibited muscles, aka like 1 or 2 hertz frequency, or 10 hertz or higher for inhibited. These are good things to know. It's good to know for the patient, the specific patient that you're treating. I know I definitely see patients where their TFL is more inhibited than tight. You've probably encountered people where you put the needle into the motor point and you're using your pointer to stimulate the needle and it's barely even moving, and you're doubting your location. And in fact, very often your location is fine, but the muscle's inhibited. So, kicking up the pointer to 10 hertz or higher and then touching the needle, you'll see you start to wake up an inhibited muscle, and then you can address the shortening of the muscle with a lower frequency. That's not uncommon. You see that on TFL. I was not surprised to see TFL has a higher percentage of type 2 fibers, but I still see TFL does get short and tight, weak because of shortening, anterior pelvic tilt because of shortening. So I think in many cases, muscles that we've been taught are prone to inhibition can also be considered as prone to shortening. I think it's good to open up our minds to the idea of phasic muscles that become short as well, like a postural muscle, or to the idea that things that we've been told were phasic muscles are actually more postural, like the gluteus medius and minimus. So, okay, I guess that's it for today. I just wanted to throw that out there. For those of you who like to read research, start looking at fiber types on muscles and things that you're treating. I think it's a worthy discussion, and I think is probably helpful for tough cases to remember that sometimes muscles that we expect to be weak and inhibited are, in fact, short and tight, like a postural muscle. Okay, have a great week, and I will talk to you soon.